Good morning.
Good morning. How are you?
Good. How are you?
I'm good.
You buzzing around getting your windscreen fixed and things?
Actually, no, today I've just been for a very wet run in the rain.
Oh, it's
And
raining.
I've just had a shower. It's raining in Manly, yeah.
Yeah.
It's
Yeah.
like I live here, can I turn my screen around?
Mm.
Oh, I can.
Oh,
Um
wow. That's
I,
lovely.
yeah, I live opposite the cricket oval, which is quite nice.
Hmm.
But it's so rainy. You probably can't see the rain, but
Mm. That's lovely. Good
very,
outlook. Yeah.
um so I've just had, and I'm meeting Zane at 9 in Belrose, so I'm gonna
Oh,
be
perfect.
driving as we
Yeah.
as
Um,
we chat. How are
uh,
you today?
yeah, good.
Good.
Yeah. Went for a lovely walk, but it's not raining, so
Hi.
yeah, but a lovely morning.
Oh, it's rubbish and raining here. Thanks for last night. It was really nice to get together.
It was nice. Yeah. It's nice to have a few things in the calendar as well where we can catch up with everyone now that everyone's kind of working like in separate teams. Like there's people I never overlap with.
Yeah, that's so true. That's not really overlap with Treen much,
No, barely ever. Yeah, exactly.
which is nice.
Hi, Jesslyn.
Hello.
How you going?
All right.
Good.
I have to do this in the car today to rush to work after.
Fine. Yeah. So the nice thing about these tutorials, because we record them, people can access them later. So it doesn't really matter if it turns up or how much attention you pay when you're here. It's the main thing is you've got an opportunity to ask questions and clarify things if you come in person. So even if you're driving around and stuff, I'll just keep talking and everyone will still benefit.
Good.
So we might as well get started. So today we're actually doing interventional medicine, essentially. So does anyone know that?
Say that again, Anna. You just dropped out there.
Oh, sorry. What does interventional medicine mean? Or minimally interventional therapies?
I guess things that we're referring to that aren't surgical, so still done by medics, but can provide both like diagnostic and therapeutic
Yeah.
procedures
Yeah.
without strictly speaking doing surgery. So, for example, using things that are endoscopically or ultrasound guided.
Yeah. Perfect. Or radiologically guided as well. Yeah. So essentially things where like typically imaging is like removed from the patient, like you're not actually administering anything or doing anything to the patient. Whereas interventional therapy is where we're actually interacting with the patient, as in we're doing things with the patient, like administering a contrast agent or utilizing equipment to provide a therapeutic benefit, essentially. So a lot of like I think I sort of did the topic for this and I was like, this is not going to apply to the vast majority of people. So anyone that doesn't have access to endoscopy and fluoroscopy, for example, isn't going to be putting subs in and all of the rest of it. So I want to make this as applicable as possible to the people like who are sort of membership level, which is where we sort of pitch this tutorial at. So the main thing I want to focus on really is the ultrasound guided interventional options and the radiology stuff that we can do. So what I will just talk quickly about endoscopy because it's probably the one thing that we've been using very long term is very kind of like it's a really nice option for patients and owners to have a foreign body in the stomach removed endoscopically rather than surgically. Shorter recovery time, often lower cost, even though it kind of often requires referral. But that was kind of the classic thing that medicine could fix, and that's the only thing that medical specialists can fix. So it's a very rewarding thing to be able to do is remove a gastric foreign body, fix the problem, send the dog out the door an hour later. But it's actually come so far from there with the availability of like different pieces of equipment becoming available and things, but also with there's a group in New York who they're a couple and they're a surgeon and a medic, and they work together. I've got sort of friends and things who are human interventional radiologists, and they work together to develop devices which will be kind of can be applied to cats and dogs. So it's a really nice combo. And what they've actually started doing is like stenting bile ducts endoscopically. So those patients who have like extrahepatic biliary obstruction from their pancreatitis, where the option has previously been like medical or surgical, and you're just sitting there going, please come down, please come down, please come down. They've actually got this option of just going in like a short anesthetic, which is like no non-painful procedure essentially, and they just put a guide wire up the bile duct, the duodenal papilla, into the gallbladder, and then put a stent in and just go and open it up and hold it open. So it's really cool, the stuff that's kind of emerging over the next 5 years or so, what we're going to see available without kind of having to go to surgery. Particularly in these really sick patients, where they're already not eating and stuff. We don't really want to be doing surgeries. So that's all I wanted to say about endoscopy. Let's focus on what systems we're interested in talking about. What systems do we use interventional therapies most commonly for?
Renal and urinary.
I think so. Yeah, by far. And I know both Helen and Jesslyn, who are here, are working in general practice at the moment, rather than in a referral centre. So what sort of problems would you see in your practices where you would have to refer for interventional therapy or make a choice about what interventional stuff you can do there?
I guess the two that spring to mind, and Jesslyn, feel free to jump in, would be if I suspect a ureteral obstruction in a cat, ultrasonographically, and the owner would be committed to going for sub placement. And the other one would be for lithotripsy, like a urethral stone that could potentially be broken down medically.
Yeah, right. Yeah, do you see a lot of them that are candidates for lithotripsy?
No, but I've had two that I can think of. Both actually while I was working at Nevs. And I guess if you really, really can't unblock them and the only other option is urethrostomy, then it's a good option.
Yeah, for sure. Another option for stones that are stuck in the urethra like that is cystoscopic basket removal.
Cool.
So because you're kind of coming up from, they're anesthetized and nice and relaxed, coming up from retrograde, like behind the stone, you can inflate with fluid around it and sometimes slip a little basket around it, and sometimes then like essentially inflate the urethra as you kind of pull it out.
Yeah.
Which is sometimes a nice option if they're really stuck, or at least push it back into the bladder. Either way, if you've got it in a basket, you can maneuver it.
Yeah, that's a good idea, because sometimes I've hydropulsed them and then been really worried about iatrogenic damage. But I guess if you've got a cystoscope and you can see, that's really nice.
You're watching and you're like inflating as you go, kind of thing, so you can really see whether you're like, you're not going up like into the wall of the urethra, you're going around the stone. Yeah.
But this is more for female dogs. It's not really for chances of male dogs who are blocked.
Well, it depends where they're blocked. So cystoscopy, we do this procedure where we actually make a little incision in the perineal urethra. So if they're blocked higher up, you can actually pull it out a hole there and then just close it up.
Oh, that's cool.
Yeah. So then that you don't have to deal with the os penis and the narrow urethra through that area. So if they're blocked in the os penis, absolutely agree that lithotripsy is going to be the best option, because you're not going to get it out there because it's so narrow. But if there is an option to bring it back up to the perineum, then that's an option. Excellent. So what can you do in general practice? So let's just talk about urethral stones to start with. What sort of interventional procedures or investigations can you do in your clinic, or do you do in your clinic?
Well, my first thing would be I don't know if this is an interventional procedure. My first thing would be to take a plain radiograph to see if it's radiodense or not and see the location. And try to unblock the patient. Obviously a bit different depending if it's a cat or a dog, the approach.
Yeah.
And like you discussed, like even if you can't flush the stone out, I've had dogs before that I can't do that, but at least you can get it back into the bladder. And then in general practice, I find a cystotomy is not too invasive or technically challenging.
Yeah. And I'm going to just tell everyone Helen has a background in emergency medicine, so she's often seeing patients when they're obstructed. But what if you've got a patient who's got an intermittent stranguria, plaquuria, and hematuria on a free catch sample, but no blood on the cysto? How are you going to investigate that dog? So they're still passing urine, they're not obstructed.
Ultrasound of the prostate or the urethral, whether there's a stenosis present.
What's the limitation of ultrasound on the urethra?
Where the
pelvis.
Yes, exactly. Right. There's a stretch of ultrasound, stretch of urethra you can't see, and the os penis as well. So you really can't see stones in those two segments. So it's really hard with ultrasound to rule out a stone definitively. What else can you do?
Oh, sorry, Anna.
You go.
You could do a retrograde contrast study.
Yeah, absolutely. Yeah. The first thing I always encourage people to do is actually a rectal, because you can feel the urethra under your fingertip. If there's a stone in there, they will hit the roof when you touch it, and you'll be able to feel it. So that's a really nice way of just kind of thinking to yourself, okay, well, there's a big tumor or there's something in the urethra. I think the problem is somewhere between the bladder and the outside world, probably in the urethra. And then you can palpate that section. The os penis, obviously you can't palpate the urethra through there, but it is a nice way to just examine that. But then the next option is a contrast study, which is where we get a little bit interventional because we're intervening with the patient. What sort of contrast would you use in urethral contrast urethrogram?
I don't know. So can you use the same IV stuff? Because it's really non-irritating.
And it's sterile. Like it's designed to be injected IV. You don't want fucking barium in there.
No. So just like a iodine-based sterile IV agent.
Yeah, exactly right. Yeah. So let's have a look at what some normal urethras look like. Oops. Oh, jumped ahead. Normal urethras. Okay, so if we have a look at this is a contrast urethrogram. So the way that this procedure is done is you've got a urinary catheter, just one of those like rigid, cheap ones. One of the keys to this procedure is actually flushing it, like loading it with contrast before you start. Because what does air look like on radiographs?
Dark, black.
Dark. So if you've got a bubble and you put it in the urethra, what's that going to look like?
An obstruction.
Yeah, it's going to look like a radiolucent stone.
Yeah.
Yeah. So really important that you load that urinary catheter before you start with the contrast agent. And then obviously you don't want to overfill the bladder. And that's the main, like, I guess, risk of doing this procedure is that you're going to overload the bladder and cause a rupture of the urinary system at some point. But essentially, like, if you think about how much volume is in a bladder normally relative to the patient size, it's actually, we don't have syringes that big. So you're not, unless the bladder is really, really full when you start, it's a very, very low risk. So what you're going to do is in a male dog, you're going to put the urinary catheter just in the tip, in the tip of the urethra down here, and then you're going to hold it. So you're going to seal it, which means that your fingers can't be in the radiograph. There's like pegs and specific devices you can use for this. But my advice would be like, just hold the tip of the penis and make sure that you're outside of your, you know what I mean? Picture? Keep your fingers safe.
Yeah.
Good. And then what you're going to do is get someone you're going to say, ready, set, go. And you're going to get someone to snap a radiograph as you flush contrast in. Why do you want to do the radiograph as you're putting the contrast in? What is the urethra normally? Is it normally got urine in it or is it empty?
This is empty.
Empty, exactly. Yeah. So the second you finish applying pressure, that urethra is going to go and squeeze all the contrast out of it, and you're not going to get your picture. So you've got to do it under pressure. And the reason I wanted to show you this is because there's actually like a couple of little dents in the urethra that can be a little bit hard to interpret when you're doing a contrast urethrogram. So particularly in male dogs, see this where the urethra goes through the prostate? Be very easy to mistake these little bubbles for stones and this divot for potentially a stricture. But this is the normal urethral sphincter mechanism and narrowing as it goes through prostate in a male dog. It's a little bit more uniform in a female dog. Then if we look in a little bit more detail, it looks like there's a leak in the urethra here. We've got some contrast agent outside the urethra. And this is actually the prostatic ducts lighting up. So this is just a normal urethrogram. There's nothing wrong with this dog. So then let me stop sharing while we talk about that. So if you did have a stone there, particularly a radiolucent stone should show up quite nicely as a filling defect. So you get a little black hole in your urethra, and just beware of black holes at those locations where we expect urethral sphincter to be. What about a radiodense stone and you've just put a radiodense contrast agent in? What's that going to look like?
The contrast agent might just stop there. So you're not going to see anything proximal to the stone. If it's causing a complete obstruction or a partial obstruction, you might just see agent leaking around it.
Good, yeah. What about if it's not obstructive? Just won't be able to see it. Yeah.
Yeah.
So the positive contrast agent will actually drown out a radiodense stone. So then what can you do to improve your contrast? Looking at a radiodense urolith.
Passing in gas after?
Yeah, perfect. So you coated that stone, you've made it look more dense with your iodinated agent, and then you're going to do exactly the same procedure, but with air instead of fluid. So then you're going to essentially inflate the urethra, and then it's like looking at a nodule in a lung. You're going to provide more contrast around that stone, and it's going to show up because instead of being a face with tissue, which is more similar in density, it's going to be a face with air, which is going to really make it show up. And then you can also see strictures and things like that as well.
Do you flush the agent? Do you flush that with saline in between those two procedures?
No.
No, okay.
No. I don't know whether you should. I haven't seen
No,
it.
you don't need to. No,
yeah,
cool.
Yeah. And it's such a nice thing. Like it's so cheap to do, you know. If you just got an iodine on the shelf, it keeps for ages.
Yeah.
It's something that gives you so much information in those patients where you're kind of thinking, oh, stranguria, hematuria, no infection present. Could there be something in the urethra? It's very helpful.
That image on the right, Anna, where there's the urethra and then the bladder and a little gap in between, is that anything or is that just an artifact?
Let me go back. Image on the right. Whoopsies. Yeah?
Sorry, the one in between.
That one?
Yeah. Yeah.
Oh, this is an interesting one. Okay. So this is a double contrast. We're not looking at the urethra here, we're actually looking at the one, we're interested in the bladder.
Yeah.
So this is pretty normal urethra coming in here. This is actually the margin of the bladder down here.
Oh, cool.
Yeah. So we've got a mass that's causing displacement of the contrast agent in the ventral axis of the bladder neck there.
Yeah.
So again, this patient might present with stranguria, hematuria, and this, what you've just done with your urethra has shown up the cause of that. So if you don't have access to an ultrasound, because these would show up on an ultrasound, nice, but you've got a really good idea of what's going on in this dog even without an ultrasound.
Yeah. That makes sense.
Yeah, so then if we look at a normal, so this is a normal pneumocystogram, just normal negative contrast. So see the shape of the bladder is that really nice teardrop shape. And then if you look at this one, you can clearly see that there's something there. But I wouldn't have picked that on the plain rad. I would, but I can see it here. The shape of the bladder is not right here. And you can say from this, it's definitely impacting the trigone. It's definitely in the neck of the bladder. Like you get a lot of information from this, even in the absence of an ultrasound. I was once, when you sort of like I've done vet school, been in specialist centers for ages, and you sort of forget about these procedures because you've got access to ultrasound or access to fluoro or whatever. And I was in a clinic doing an ultrasound once, looking for ectopic ureters. And I arrived to do the ultrasound, setting up the ultrasound machine, and the vet comes out and goes, "Oh, I actually don't need the ultrasound anymore." I was like, "Well, why? What do you mean?" And he'd done this antegrade urethrogram. So he'd essentially, rather than do it, because we talked about contrast urethrograms with male dogs, but with female dogs, you can just put the contrast in the vagina. So you essentially inflate the vagina with, so seal off the lips of the vulva, inflate the vagina with contrast agent, and it goes up into the vestibule here, vagina, urethra, definitely not entering into the bladder, left and right ureters. Can you see that? So this is a dog with ectopic that literally is diagnosed by flushing contrast into a vagina. So if you apply enough pressure, you can inflate those urethras and see that it's an ectopic patient. And it's actually probably more sensitive than ultrasound, looking for them, because ultrasound, it's very difficult to be able to say definitively only 70% of the ureters will be dilated or abnormal. And unless you kind of see ureteral jets, like urine flowing from the ureters into the bladder, it's very hard to document whether it's ectopic or not. So I was sort of like looking at this radiograph going, it's way more information than I'm going to give you from this ultrasound. I agree, you don't need the ultrasound anymore.
What do you typically recommend that now, or what do you think is the most sensitive, or an IV contrast study for looking for ectopic ureters?
So that's interesting. So what are the limitations of IV excretory urethrograms?
You can't use it in azotemic or dehydrated patients.
Wow.
Like it's mildly toxic.
Does the ectopic urine, is it intermittent that it squirts into the vagina?
Yeah.
So sometimes you don't see it.
The density, so once the contrast agent's gone through the whole bloodstream, like whatever you've injected IV is diluted in the entire blood volume, right?
Yeah.
And then it goes into the kidneys, and you can see it go into the kidneys, but the actual concentration density of that contrast by the time it's going down the ureters is pretty limited.
Sure.
So if the ureter's functioning normally, like if you don't have ectopic ureters, you don't have ureteral dilation, you don't have abnormal ureteral function, then you're not going to see anything, because the little pulses of urine go through the ureter. Like chances of catching that on a radiograph are 0. So it can be a nice rule-in test. Like you can do a excretory uregram and say, okay, well, I can't see ureter. I can definitely see dilated ureters, and therefore I should be concerned about ectopics.
Yeah.
But if it's not there, you can't rule them out. So we do. It's not I can't remember. I'm so bad at sensitivity and specificity, but it's not a sensitive test. It's a specific test.
Yeah.
Okay.
Do you find you need to do a combination of those tests on patients if you're worried?
I can't remember the last time I did a intravenous contrast study.
Okay.
I just don't. We've got better options now, because we do have ultrasound available, and one of the indications, for example, would be looking for a ureteral obstruction, where this retrograde flushing of contrast isn't going to be as like if those ureters are entering into the bladder, you're probably not going to get any contrast up the ureters.
Yeah.
If you're doing this study, it's that you're only getting contrast in the ureters because these are ectopics. So if you're looking for an obstructed ureter, then you're not going to see it on a retrograde study. So then an IV contrast study might make sense if that kidney's producing urine. So if it's been obstructed and there's back pressure, the contrast is never going to get into the ureter. So that's one limitation of IV. And then now that we've kind of got the option, I will just flick ahead, of doing an ultrasound guided antegrade pyelogram.
Oh.
It's cool, picky, hey? So now that ultrasound's fairly readily available, you put the probe on the renal pelvis, and if it's really dilated, so most of the references say it's got to be more than 4 millimeters to attempt this. Then there's sort of a few different indications to put a needle in that renal pelvis. And if you've got a sterile contrast agent on the shelf, then you can do a procedure called an antegrade pyelogram. What you do is use an ultrasound to guide the needle into the renal pelvis. You take a sample of the urine from the renal pelvis, which helps you screen for either concurrent pyelonephritis or primary pyelonephritis as the cause of your pelvic dilation. And then you take a little bit of the urine out for your sample, and then you replace that with iodine. So you leave your needle in place, you just swap out your syringe. Most people recommend doing it with 2 people, so one person holding the probe, so you're watching the whole time, the other person doing the needles and syringes. And you put a little bit of iodine in, and it gives you a like really densely concentrated contrast of the renal pelvis and whether the ureter is patent. So this study here, these are 2 different patients, 2 different animals. This study here, you can see filling defects along the length of the ureter. So we've got a stack of stones in this ureter. Most ureteral stones are too small to see on radiographs. They're not dense enough to see on radiographs. So often we don't see them on a plain radiograph. So we've got a stack of filling defects along this ureter. Oopsies. And then we've got actually the ureter still going right down to the bladder, but no contrast agent in the bladder. So this ureter is probably at least partially obstructed, if not fully obstructed.
And now, could I ask, on ultrasound, will you be able to see the stones?
Not always.
Not always.
Yeah, I think it's like 70%, and obviously that's so user dependent. I don't specifically, like I do look for them, like I've tried and traced the ureter along its length, but there's so many artifacts and things, like particularly left kidney, the ureter is like wrapping around the colon, and so you lose it. There's no way you can see the full length of it, kind of thing. So I always look for them, but I would never say I can't see a stone and therefore it's not obstructed. If I see a dilated ureter, I want to know whether it's obstructed or not, and I'm not going to make that call on ultrasound. I'd recommend doing this as a next step. And then, yeah, this one you can see, again, I can't see the stone, but I can see that the column of contrast just stops there. You see that? And in doing this, the risks are that you put a needle through renal tissue and potentially cause some damage. But that risk is a lot lower than an IV, the risk of giving that contrast IV and compromising renal function more that way. And also a lot more diagnostic. Make sense?
Yep.
After injecting, are those radiographs at like 0, 5, 10? Yeah, okay.
So they do, I think it's like 1 minute after. So I usually do these injections on the radiology table.
Yeah.
And then just do it straight away. And then even up to half an hour afterwards, just to see whether any contrast has started to kind of seep past into the bladder. And you can see it pool in the bladder in these patients. Yeah. There is like quite a set protocol for this, but I can't remember. Because usually you've kind of got your answer. I'm not interested anymore. By that stage.
Yeah, that makes sense.
Cool. Yeah, this is one of my favorite things to do, just as far as like it's so definitive, it's so sensitive. Like obstructed, not obstructed. And you've got your sample to culture in case it's pyelonephritis. And often, and I know we've talked about this before, but often pyelonephritis is concurrently present with a ureter obstruction, particularly in dogs. So it's a nice one to be able to, like, I guess if you're talking about putting an indwelling device in, like a sub, you want to know whether there's an active infection in there and what antibiotic to treat it with before you put your device in there. And in doing this procedure, you actually decompress the renal pelvis and bought yourself a little bit of time to wait for those results to come through. Okay. Excellent. All right. So they're the main indications for urinary interventional kind of radiology stuff, like the stuff that you can just really help you get answers in general practice just with one bottle of contrast on the shelf. Have you got anything else that you
Yep. Could I ask,
yeah.
in the urethral, ectopic urethral segment,
Yeah.
is there a chance that so it's always a congenital problem? There is no chance that it might be an older dog having chronic vaginitis?
Yeah, I would say, yeah, absolutely, yes. So we've got a lot of particularly male dogs whose urethral tone when they're younger has been sufficient to maintain continence despite the ureter entering into the proximal urethra.
Yep.
And
Okay.
then as they get older and they lose that urethral tone, they become incontinent, and then we'll be able to diagnose an ectopic.
Right. So even in female, that can happen as well in female dogs, would you say?
In theory, but what I would probably say is that it's probably a low volume leaking into the urethra, because their urethra is not as long. They don't have as much buffer to like create tone along it.
Okay.
It
Yep.
could have like a unilateral ectopic potentially. So it was only half the volume. And it might be really proximal in the urethra, and there might be a bit of backflow into the bladder, so that it's not kind of pooling. But most of the time, females with ectopics will be incontinent. It's pretty
Okay.
rare to diagnose a female late in life.
Okay. Yep.
Yeah.
Thank you.
No worries. For other things that are really fun to do in the urinary system is actually the sort of device placement and the process of unobstructing dogs in particular, because cats are too small to do anything fun with. So dogs with ureteral obstructions, we tend to put stents in rather than subs. Do you guys know what I mean by subs and stents? Yeah, cool. So essentially a sub is a subcutaneous ureteral bypass. So it's essentially placing an artificial ureter. And those devices, they've been developed by that team in New York I referred to, who are very exciting in the work that they're doing. But they've come a long way. So they were just essentially a tube that went from the renal pelvis into the bladder that was completely inside the animal. And then they realized they were getting mineralized and blocked all the time. So they put a little port that like just sits under the skin, and you can flush it through the skin. So you can palpate the port, it's readily palpable, and put a needle in there, specific type of needle, so you don't like put holes in the membrane, and flush an anti-chelating and antibacterial agent into there to decrease risk of pyelonephritis and at blocking. So that's what we typically use in cats, because they're kind of too small to, no, I shouldn't say that. They're not to have stents. So most people recommend subs in cats and stents in dogs, and the other reason for that is, I might have to do a little bit of arts and crafts here. Maybe. Blackboard, that's what I want.
Anna, if you have an owner that's keen for a sub and that's what you're suspicious of, is it better to not stick the renal pelvis at all and leave it dilated?
Yeah.
Okay.
If it's really dilated and you're like, pyelonephritis can cause like quite significant dilation.
Yeah.
But if it's over probably 6 or 7 millimeters, it's probably obstructed. And I guess the reason to do that antegrade pyelogram is to diagnose an obstruction. But if you've got like that information and you think, it's really probably obstructed, it's over 7 millimeters, I would send it up for subplacement with the renal pelvis full, because it's much easier to get the catheter in, because the catheter's got a pigtail on the end, a curl on the end. Much easier to get the catheter in when the renal pelvis is dilated, whereas if you've decompressed it and then that kidney is not producing urine anymore, so it's not going to refill, it's going to be technically harder procedure for them to get it in, and therefore potentially less successful.
Sure. And if you've got a unilateral, oh sorry, Anna, you go.
I just said good point.
If you've got a unilateral dilated renal pelvis, say it's not 6 or 7, it's like 4 or 5, but it's unilateral. Do you see many primary pyelonephritis unilaterally without there being a reason, like a nephrolith or some causative reason rather than it being bilateral?
Yes, definitely. Pyelonephritis is often unilateral.
Interesting. Okay.
So if we look at the anatomy of the urinary system, normal urinary system. So we've got kidney up here, ureter coming down, and then we've got the ureterovesicular junction, which is this bend in the urethra right before it plugs into the bladder. Now, the reason for this is to actually decrease urine flow into the bladder as the bladder fills up. So if you look at this kink here and think about that bladder getting fuller, that kink is going to actually kink off. So it's going to actually kind of almost seal off urine flow from the kidney into the bladder until the patient has time to go to the toilet, or opportunity to go to the toilet. Does that make sense?
Yeah.
So we've got a little bend in the ureter here right before it plugs into the bladder. So if we're going to put any device through the ureter, it has to be able to go around that bend. Now, cats' bladders, that enters in right down here. So if you put a device in that curls around here, it tickles the bladder wall all the time, and we see plaquuria associated with that. Whereas in dogs, it enters in up here and actually doesn't annoy them quite so much. We still do see some dogs get annoyed by their catheters. So typically stents are less well tolerated in cats, but some authors still recommend them at over subs. The nice thing about a stent, does everybody actually know what a stent is? No? So there's this device that goes like this, and that's just how it sits. So you choose the length of the device, and most clinics that are placing stents have just got a range of stents in stock, but you essentially measure the length of the ureter, and then we're going to use our ultrasound to place, or fluoro actually, to place a needle into the renal pelvis. Then we're going to feed a guide wire down through that needle, down through that ureter, into the bladder.
And it pushes the stones out? Actually
goes past the stones most of the time. So the stones are still sitting in the ureter here, and it actually goes just straight past them. So you're going to put a wire in there, and then you're actually going to cystoscopically grab the wire and pull it out. So then you've got a wire coming out body wall, through the kidney, down the ureter, and then out through the urethra. And then you literally just push this stent, which is a tube. So you straighten it out. You put it over the wire so it straightens it out. You push it up over the wire until you can see it's got a little radiodense marker, until you can see that in the renal pelvis. And then you just pull your wire out through the urethra. Whoopsies. So then this little pigtail up here, that as you pull your wire out, it curls around so it can't pull out easily. And then you keep pulling your wire out. So then you've got the caudal pigtail in the bladder, cranial pigtail in the kidney. And what that actually does is it's not designed for the urine to run through the stent. It's designed to, if you've got a stone sitting here and this tubular structure like this, and it was sandwiched around that stone and completely obstructed, it's just holding a little bridge open. So then, so if you've then got two circular structures sitting on top of each other, there's then this little window for urine to run through either side of that. Does that make sense?
Yep.
Yeah. So stents they're not They don't carry the urine. They're not artificial ureters. They're literally just holding that ureter open and stopping it from getting obstructed again. The nice thing about them and what they facilitate is decompression of the renal pelvis. So you maintain renal function, or you salvage renal function, I should say. And then if you get rid of the back pressure behind that obstruction, the spasm in the urethra relaxes. So where that stone got stuck, the urethra is like holding on tight to it, and that's making the obstruction so much worse. So then when you relieve the obstruction, the muscle of the ureter relaxes, and most animals and people actually pass the stone once the stent's in. So you just bought them some time, relaxation, comfort to relieve the degree of spasm. And then it allows them to pass the stone. So then the other nice thing about this rather than subs is, say we document that they pass the stone and the stent's annoying them, or they get a cystitis and we're worried about having an indwelling device. Literally like bolus of Alfaxan, cystoscope, grab this end, pull it out. 5-minute procedure to remove it with like no risk essentially. So really, really nice devices just for a temporary fix kind of thing. The trouble is they're bloody expensive, isn't it? It's always the way.
Is there a weight limit on a dog you can do that on?
They definitely do them in cats, so less than 5.
Oh,
yeah.
okay, cool.
The main limitation is that the facility has to have a cystoscopy that's able to get into a cat urethra.
Tiny. Yeah, sure.
Yeah. So a lot of facilities, like, they're so expensive, won't have invested in that. But like Vsauce and Sash are definitely doing stenting in cats, I believe, when sub's not an option.
Yeah.
Yeah.
It's cool.
It is. It's very cool. Very cool what they can do.
Are they a completely different device to what people put through, like the prostate, if you've got a carcinoma that's causing occlusion of the urethra?
Good point. Let me find a picture of that. Completely different device. Yeah.
Okay.
I'm just going to find a picture of this and share it with you.
And now, since we're waiting, do you mind if I ask a question,
Please.
urinary question?
Yeah.
So I have a 9-year-old Maltese that keeps having stranuria, hematuria, and the past 10 months has been coming in and out of the clinic for just a UTI. So the bladder looks fine on ultrasound. I've started, there's no signs of leaking of urine or incontinence, but I started strabisral at the very end, and that still didn't help. You can see mucoid discharge dripping from the vulva.
Yeah.
Went in, so suspecting possible, I guess the cervix looks a bit dilated, or maybe it's a what's it called? Maybe it's a stump pile. Went in, removed that inflamed cervix, came back now. It's actually not a stump pile. So we are still back at square one with chronic vaginitis and stranuria whenever we stop the antibiotics. Where would you go next?
So you've done a cystoscopy to look at the cervix, or a vaginoscopy?
So we have done, yes, I guess a brief one. Had a look, didn't see really much. I guess nothing too abnormal to our eyes. But of course, with a ectopic, sometimes you might not be able to see it on vaginoscopy. So
exactly, yeah. So normally it enters into the urethra, so you have to have a look inside the urethra.
Okay.
Sorry, I'm just getting these in. So I would be very suspicious that there's something going on in the urethra, because vaginal abnormalities shouldn't cause stranguria.
Okay.
So then I think like this is a really good candidate for one of those contrast retrograde vaginourethrograms.
Okay.
So you'll see the urethra, you'll see the bladder, you'll see the vagina, you'll see the relationship with all those structures really nicely in that study.
Okay.
So that would be my next move for that one. And then have you done a rectal?
Yes.
Yes.
We don't feel anything. Nothing. So we're a
The
bit
other thing that might be nice to do in this dog is actually one of those cadet BRAF tests. How old did you say?
9.
9, yeah.
Oh, TCC.
Yeah, just in case, because they can be very annoying.
Okay.
In that they can just be quite focal in the urethra, just annoying the urethra, causing urethritis.
Okay. All right. Thank you. Yep. So
Yeah,
I'm a bit stuck. I don't know what to do.
a couple of things to work on.
Okay.
But yeah, I'd be focusing on the urethra, I reckon.
Very true. Okay.
Okay, let me share this again. Okay. So sorry, I know you're actually driving, so it's probably not ideal to be sharing it, but you can always have a look at the pickies later. So Helen asked whether the stents that we use for urethral like TCCs and things or obstructions, strictures and stuff were the same as the stents that we use, the pigtail stents we use for ureteral obstructions, and they're actually quite different. So a urethral stent, I wish I could show you a video. You should definitely Google this because it's very cool. A urethral stent is actually like a mesh wire cage almost. And you can see it on the left-hand side of the image here. So what happens is this cage is wrapped around a catheter. Oopsies. So this is a picture, this is a fluoro sequence of still. So the contrast is inverted compared with a radiograph, but you can kind of see what's going on, right? Over here. So instead of contrast being bright white, it's dark on fluoro. So it's just inverted. So what we do when we're placing a urethral stent is first do a contrast study. So this is our contrast urethrogram, penile urethra, membranous urethra, prostatic urethra through here. See that little divot? And then there's a narrowing through here. So then what we've done is run a catheter up through that urethra. We've got our radiodense markers on so the catheter has a stent wrapped around it. So the stents come wrapped around a catheter. We've fed that catheter up over our wire and we've put it to bridge that like narrowed area of the urethra. And then we've essentially like pulled the trigger and the cage goes thunk off the catheter. It's really cool to watch. Like it goes from, because you kind of essentially like pull the cover off it, which allows it to spring open. So it springs open like one end to the other. And then it holds the urethra open. So you can see the image here where now you've got a cage in the urethra, and contrast wise, we've got a urethrogram here and you can see the width of the urethra at this cage relative to what it was before. So it's holding that wide open. It's actually almost exactly the same device as we use to stent tracheas in collapsing trachea dogs. So it just is essentially this really strong metal cage that holds tubular structures open. Also use them in the esophagus for dogs with strictures.
Oh, that's so cool.
Yeah. This is one of my funnest procedures. I miss stenting a great deal.
And do you decide how long that stent's going to be in the urethra from the contrast study before, like however long it's narrowing for, or do you scope them and have a look macroscopically?
No, it's on fluoro radiograph. So if you might notice the marker up here.
Yeah.
We've got a centimeter marker in the rectum, so level with the urethra. So it's not like so we can kind of measure without any depth perception changes and stuff. This is more accurate than like just using like Asteris or something like that to do a measurement.
Yeah.
Then we sort of say, okay, well, we want a stent to go from here to here, and it's going to be 5 centimeters. And then we're going to choose our stent length and width. based on the inflated diameter of the urethra and the healthy urethra, and then overestimate it because we want that stent to stay in there, right? We don't want it to just be the width of the urethra and then come out.
Yeah.
With urine flow. So we want it to be a little bit wider than the width of the maximal width of the urethra. And then we want it to be longer, like by about 1 centimeter either side than the stricture.
Yeah.
So the downside of these is that tumors can go through them. So it kind of can get integrated into the wall with tumors. But with TCCs in particular, so if you just give them non-steroidals, if they present with stranguria, you just give them non-steroidals, they've usually got 3 to 6 months of life left. If you give them non-steroidals and chemo, you can push it out to kind of 6 to 12, depending on how affected they were. If you only do a stent, the average survival is 12 months. So the cause of death in TCCs is stranguria and obstruction. And these relieve that obstruction with like actually very low, like it's a non-painful procedure. I'm sure it's uncomfortable, but it's like a day surgery. They're in and out that day. It's under fairly light anesthetic because it's a non-painful procedure. There's no cutting, no healing required, and you just bridge that gap that the tumor is like compressing. So you do buy them a lot of time, and if you can then piggyback that with chemo, the survival times is really like a lot better. The downsides of them are you can sometimes get incontinence, particularly in female dogs, where then you like stented the whole urethra open. And I think it's like it's a surprisingly low rate. It's somewhere between 25 and 40% of dogs will be incontinent afterwards. And they can sometimes fracture and sometimes like push through the urethral wall. You can imagine like if a wire comes loose kind of thing. They can actually push through the urethral wall, but I have to say I've never seen it fracture in a urethra. I've definitely seen fractures in tracheas where they're under more like dynamic force and stress. But yeah, there are instances of like the devices kind of coming through urethral walls and stuff like that.
Have you had issues with them like forming a biofilm and patients that get recurrent infections in them?
No, actually.
Or not so much. That's good.
No, yeah, not with these ones.
Yeah.
So I think that the metal, I don't know.
Maybe it's impregnated or something.
Yeah.
Yeah, that's cool.
Interesting. Yeah. Yeah, they're very prone to infections because the wall's really irregular.
Yeah.
So you've lost one of
Yeah.
the defense mechanisms, but not more so, I don't think, with stents in place.
Yeah.
Definitely in tracheal stents, sometimes these animals with like really like their trachea is so collapsed it's this shape, and you put a stent in and there's still like little gutters, they call them, and mucus can kind of collect in there and they can get pretty raunchy infections, but generally very well tolerated. And it's really fun to do, in case you didn't get that.
Yeah, that's cool.
Yeah. So they're the things that I kind of wanted to cover because they're the most applicable to most of our the people who watch these. Is there anything else you guys are interested in, like what's available or anything like that? Because this, I mean, like cardiology wise, like the stenting, ballooning and stuff like that they're doing is pretty amazing. But really for patients that need, like most of the time they've been referred already by the time they're diagnosed, so they're not ones that are applicable for you guys. But pulmonic stenosis, like if I've got a patient breed wise that it's a young dog with a murmur, I usually say to people, if they book an echo with me, I usually say, I think you should probably go and see a cardiologist. It's a high chance it's going to be pulmonic stenosis, and they might recommend ballooning, and therefore you should get the person that would potentially do the ballooning to do the echo rather than then have them have to repeat it. And then it's the same equipment as like, you know, measuring the before and after. So yeah, the cardiologist has to do the echo, so to make sure that they've got the velocities and stuff. But yeah, they can like open up those valves if there's a stenosis there. They don't do that with aortics. No, yeah, it doesn't change the outcomes with aortic stenosis. And has everyone seen the Amplatzer occluders that they use for PDAs? No, they're cool. It's like essentially like a bath plug. They just put in the hole and go, "Funk," and it just stops the flow through there and just like fixes the problem. It's amazing. We also use them for intrahepatic shunts. They put a stent in, this stent actually, and then under fluoro guidance. So this stent goes in the caudal vena cava where the shunt is dumping into. So you hold the cava open, and then you put a catheter up the femoral vein or cava. No, wait. Femoral vein. And then go through the holes of the stent, oopsies, into the shunt. And then you deploy a whole heap of like pro-clotting things. So little like discs that like you like push them through the catheter and then they go funk and can't come back through the holes and get stuck in there, and then it just causes occlusion of the like gradual clotting in the shunt. It's so cool.
That's very cool,
isn't it? So when it's not surgery, like if it's intrahepatic and surgery is not an option because it would be too invasive, you'd have to cut out half the liver. They use this to block them off. And they actually, like, oh, there's so much cool stuff, like delivering chemo directly into tumors and stuff like that as well under fluoro. Very good stuff. All coming soon. All right, we might wrap up.
Yeah, thanks, Anna. That was
thank you so much.
That was really helpful.
So glad that you guys could talk to me. I was thinking if you guys are both driving, this is going to be really boring.
No, that was really helpful. I'm sure Jess would agree.
Yes, definitely.
Awesome. All right, get yourself some iodine.
Yes.
All right. See you guys.
All right. Thank you.
Thanks.
Bye-bye.
Bye.
Bye. Bye.